Hi, and welcome to SpondyCast, where we bring together the best medical minds, thought leaders, scientists, patients, and caregivers to inform and inspire the spondylitis community. I'm your host, Jill Miller, living my best spa life, knowing that how we meet today has the power to change everything going forward. Hi, and welcome to SpondyCast. Today, my guest is Dr. Jean Liew. Dr. Jean Liew graduated from the University of Texas at Austin with degrees in biology and English and went on to earn her MD at the University of Texas Medical Branch in Galveston. She relocated to the Pacific Northwest to complete an internal medicine residency at Oregon Health and Science University in Portland, followed by a rheumatology fellowship at the University of Washington in Seattle. She concurrently earned a Master's of Science in Epidemiology through the University of Washington School of Public Health. And during her fellowship, the primary focus of her research was in axial spondyloarthritis, specifically ankylosing spondylitis and cardiovascular comorbidities. She is currently the Assistant Professor of Medicine in the section of rheumatology at Boston University, where her clinical research focuses on knee osteoarthritis and axial spondyloarthritis. Additionally, as a member of the COVID-19 Global Rheumatology Alliance and a member of its steering committee, she has led multiple projects relating to data collection, analysis, and dissemination of the impact of the COVID-19 pandemic on individuals with rheumatic disease. Dr. Liew, thank you so much for joining us.
Thanks for having me.
You have done a lot of really interesting research over the years. I've had a chance to take a look. And what we're going to talk about today as our topic is the Spondylitis Association of America's Early Career Investigator Award. I'll give a high-level overview, and then we can dive into some questions around your research and really how you came down the path toward rheumatology and ankylosing spondylitis. So the Early Career Investigator Award is something the Spondylitis Association of America provides every year to rheumatologists who are early in their career and looking to expand horizons. As part of the ongoing mission of SAA, they look to expand horizons in spondyloarthritis research. The Spondylitis Association of America hopes to encourage new up-and-coming rheumatologists and researchers to focus on the future of treatment and research in ankylosing spondylitis and related diseases. To this end, we created the Spondylitis Association of America Bruckel Early Career Investigator Award, which recognizes outstanding contributions to the care and understanding of patients with spondyloarthritis. The awardee receives a grant from Spondylitis Association of America for use in spondyloarthritis research, and the award, named in honor of our co-founder, Jane Bruckel, is given annually to the early career investigator who shows the most promise to contribute to the understanding or therapy of axial spondyloarthritis. Indeed, past awardees have gone on to be leaders in the spondyloarthritis research and education areas. And Dr. Liew, you were the winner this year. So what is your involvement in research related to spondyloarthritis?
Yeah, so I've been involved in spondyloarthritis research since 2018, and currently have multiple projects ongoing. But I think maybe it's easier to kind of start with, how did I get started? So by chance, in at the American College of Rheumatology meeting in 2017, I ran into Leanne Gensler, who is a spondyloarthritis expert at UCSF, and she was the 2012 winner of this Bruckel Award, I want to add. And that was the start of our mentor-mentee relationship. So in this chance meeting, we established this relationship, and she started mentoring me in research in this specific area. And very specifically, I worked on cardiovascular risk factors and spondyloarthritis. So those were my first projects that I did, the first research that I did with her, using data from a cohort of patients that she has helped assembled. So that was a kind of the first area. And then from there, I have expanded my work to many other aspects of spondyloarthritis, including treatment, guidelines, management, just a lot of different things. So I think we could talk about some of the specific projects, or whatever would be best.
We can do a little bit of both, but I'm very glad to hear and very fascinated to hear the evolution of the connection with you and Dr. Gensler. That I don't know that we need to discuss it, but it's really a wonderful thing to hear how uh, from one, I know she's not an older woman, but from one generation to the next, right? From one generation.
You'll have to cut the show hate knowing that.
We get canceled. What were you focused on before spondyloarthritis, out of curiosity?
um, so actually, if we go back into how I got into spondyloarthritis at all, not the research aspects, I actually have a friend with ankylosing spondylitis, and before I even started medical school, she told me to consider becoming a rheumatologist. I didn't know what a rheumatologist was. So I am first generation, as in first generation to attend college, definitely medical school. All I knew about doctoring and medicine was from reading books and watching TV. Grey's Anatomy started when I was a junior in high school, and like I watched ER before that. That's all I knew. So when this person who knew me and recommended that I look into this specialty that they felt would be a good fit for me, personality wise, I really strongly considered it, because I said that's great, because otherwise how do people even make a decision on what field you choose, because medicine is so vast, so broad, and you have to make so many decisions at all times what you're going to pursue, because um, there are multiple levels of training, and then each level is many years long potentially. So entering medical school, I thought, okay, I'm going to do internal medicine, which is a broader field, broader specialty. And then after that, I will consider pursuing rheumatology, which is additional training after doing internal medicine residency. So in medical school, then I got to connect with a rheumatologist, who he wasn't a researcher, but he was a really great clinician. And being able to watch him with patients and just watch the trust they had in him, watch him explain very complex things to patients, it was just really great. And he was just a really great role model. And that was just one of the things that really cemented this idea that I was going to become a rheumatologist. So it's actually very rare that people decide on rheumatology in medical school, and rare still to have people who go into medical school thinking that they might become a rheumatologist. Perhaps if you have yourself are living with a rheumatic disease, or know someone or have a family member living with a rheumatic condition, you might be more primed to consider rheumatology. But a lot of people in medicine don't really get what what cool things this field has to offer. If you're a clinician, if you're a researcher, you're both. So all of that happened many years before I had that chance meeting with Dr. Gensler. So when I met her in 2017, I'd already been on this journey for since 2009. That was 2009 was when my friend told me I should look into becoming a rheumatologist.
Well, thank your friend for us.
Maybe they're listening. I'm going to have her listen, actually.
Absolutely. It's amazing. What do they say? You miss 100% of the chances you don't take. And sometimes just sharing with someone you think they'd be great at something changes people's lives. In your research, and you have done extensive research there, you have a lot of research out there. And I think you're a problem solver also, which is something that lends itself well to rheumatology. Are there specific focus areas that you're working on right now?
Yeah, so when I tell people about just my research in general, so I do clinical research. So I do I look at data that comes from patients. I don't work in the lab, so I don't work with like chemicals or animal studies or things like that. I do data from patients in some sense, like either symptoms or lab tests or imaging data that come from patients. So that's the field of research I work in, clinical research. And then in that area, I do spondyloarthritis research, and then I do osteoarthritis research, specifically knee osteoarthritis research. And of course, I've been doing the COVID research as well. So those are my 2 or 3 areas. In spondyloarthritis research. So I'm still doing some cardiovascular disease, cardiovascular risk work. So that's a broad category for me. I'm doing a little bit looking at fracture risk, osteoporosis with a colleague of mine. Actually, this colleague is the 2018 winner of the Bruckel Award. So we're all just a close knit family here. More recently, I'm starting some work looking at chronic opioid use and pain in spondyloarthritis, and seeing if any of the treatments, other recommendations like exercise, can change this need to use medications like opioids. So those are the big things that I'm doing. Behind me, I have a whiteboard on my wall that's just taped on my wall with all my research projects, and just trying to make sure I'm capturing everything. And then there's some bigger projects that I am just a small part of. We are looking at referral recommendations for primary care providers for chronic back pain, because as you know, diagnosis can be difficult and can take years for spondyloarthritis. So trying to figure out if there are any evidence-based, evidence-driven recommendations that we can give primary care providers so that they know to refer people with chronic back pain that have certain aspects or features to rheumatology for evaluation. That's a huge project that we're doing, and that's through Spartan, Spondyloarthritis Research and Treatment Network. And then the American College of Rheumatology is revising the guidelines for the treatment and management of spondyloarthritis. So that's something that we're going to get started doing as well. What else? What else am I doing? I have some collaborations looking at some little things that have to do with spondyloarthritis, psoriatic arthritis. And then I am a member of Spartan. I'm a member of ASAS. That's the International Society of Experts in Spondyloarthritis, and I do various things related to research and communications, and I manage social media. I do a lot of different things in the field that may not be directly related to research.
Do you sleep?
I sleep a little bit. Yes. A lot of so I'm a really efficient person, and a really organized person. So I try to do everything. I try to fit a lot of big things into a short amount of time.
I know that feeling. So will one of these projects be supported specifically by the Early Career Investigator Award?
So my ongoing projects, all of these ongoing projects are currently supported by this, because this award supports publications. Because when you publish things in journals, some of them require that you pay thousands of dollars to have the paper be available for everyone to read. And it's just it's a sad thing about science, because a lot of times I hear patients, especially on Twitter, comment that they have no access to these papers about their conditions that they're living with, and they have to ask people to send them a link or email it to them. And these fees can just be just huge. So that that is one part of where the funds are going. Also, to support me working with trainees, people that I'm mentoring, and just helping them out, as well as supporting travel to meetings to talk about this research and network with other people interested in spondyloarthritis, and start doing more collaborations with people so that we can do bigger things.
I love the collaboration idea. The world it's changing to where if we collaborate, I think we move mountains.
Yeah, and with the COVID-19 Global Rheumatology Alliance, we really learned that. So we recently just lost our founder and the lead of the GRA, Phil Robinson. He was a spondyloarthritis expert in Australia. He passed away suddenly at the beginning of the new year. And it was really like his driving force that he was got all these people around the world to do something big and to gather really important data to learn about how COVID affects people living with rheumatic disease. Something that just started with an idea on Twitter in March 2020, and we learned so much. We got so much done. So many people working together remotely, something that just never happened before. He thought it could happen. He got in there, rolled his sleeves up, and worked alongside us and made it happen. And it was just an amazing thing. So if we learn something from that experience, is that we need to keep these collaborations going. We spent so much time working together and got so much accomplished. Why can't we continue doing things together, doing things across across different countries and working together even remotely? We don't have to be in the same room to do big projects together.
I think that's fantastic. Although I do think the human interaction rolls it up if you can be in the same room with some people. Uh, what is the saying? A small group of thoughtful, committed people can change the world. I think you're onto something. The the other part is we all had a little more spare time during COVID, and I wonder if it's going to change. I just read a study that said the average American got 72 extra minutes a day.
Yeah, yeah. So at the last ACR meeting, the new ACR president asked me what factors I thought led to the success of the GRA. And a big thing was that people who were researchers and people who were clinicians, suddenly their jobs just changed in a big way. And a lot of people had to stay home and either not work on things that they'd been working on altogether, or they had to work in different ways. So it was that we were all kind of blocked from our usual duties, that we had time to funnel all this energy into doing this project. But for those of us who continue as researchers, we have funded time to do this kind of work. That is part of our jobs. Um, so if we can harness the collaborations and the things we learned about working remotely effectively, we can do those things. Then I think we can figure out new and innovative ways of doing research that is helpful to people.
That's amazing. So I would love to come back to the work you're doing around research around opioids. Can you tell
Okay.
us a little bit about that? And then we can dive a little more into a couple other patient style discussions.
Yeah, so pain is, as you know, it's a pretty predominant symptom of having spondyloarthritis, and the pain is caused in part by the inflammation in spine and other joints. Um, and when we bring down the inflammation with medications, like biologic medications, like TNF inhibitors, that reduces the pain, reduces the symptoms, but there are people who, despite being on these very effective medications, still have some remaining residual pain that really affects their quality of life, affects what they can do on a day-to-day basis. And we don't have a good enough understanding of what's driving this pain. And then because we don't have a good enough understanding of what's driving this pain, we don't have a good understanding of what to recommend to really treat that pain. So um, in the absence of knowing like specific targets to reduce pain, many people have to take medications that are known as painkillers, and these include opioid medications. So these are like hydrocodone, oxycodone, medications like that, tramadol. and these are not things that remove the source of the pain. They just basically kind of block the pain for some short amount of time. But they the body can develop a dependence on them so that you end up needing higher and higher doses. And in some people who have other medical conditions or who are older, having to take higher and higher doses of these medications can be really risky because it can cause sleepiness, it can cause mental issues like issues with thinking, sedation, can cause falls, can affect even your breathing. So these are all reasons why it would be really great if we could figure out ways, apart from use of opioid medications, to treat pain effectively.
And would that be clinical research as well?
So it's clinical research. It's also basic science research, but from the clinical research angle, I can ask questions like, if you start TNF inhibitors, these are biologics, start them earlier compared to not starting them earlier or not starting them at all, does that reduce the risk of needing to be on chronic opioid medication? So being on things like oxycodone, hydrocodone long term. So I can take information from a lot of individuals in a database, like an insurance database, where I can figure out if these people have a diagnosis of axial spondyloarthritis, ankylosing spondylitis. I can figure out if they were ever prescribed a TNF inhibitor like etanercept, infliximab, or others. I can figure out if they were ever prescribed opioid medications for 6 months or longer. And then we can run these studies using statistical modeling to try to get at the answer to that question. So that's one of the ways that we're trying to answer the question. Another way could be, if you exercise or do physical activity at a certain duration or frequency or intensity every week, compared to someone who doesn't do that, does that make you less likely to need chronic opioids to treat your pain? So these are just questions using data from or about people living with spondyloarthritis to try to answer this question. Other ways you could answer the question would be designing a trial where you gave one group of people some treatment or some treatment recommendation and had another group that didn't do that treatment or treatment recommendation. And you try to figure out, by following them over some period of time, if their pain gets better and stays better.
Interesting. I love the power of data with the electronic health records that we now have that we didn't have really 15, 20 years ago, maybe even
Right.
5 years ago. We've really been able to harness it. So when you do actual like intense clinical research, what is one of the questions I think listeners are always interested in is, what is a patient's involvement in a piece of research potentially, or would they actively be involved in a research study?
Yeah, so that's a really good question, and there are a lot of different ways to answer this. So I think in Europe and in the UK, patient involvement in research is more it's more standard, and it's more part of research protocols than it might be in the US. So in a lot of scientific journals, they have a part that you have to fill out asking about the specific patient involvement in that research project. But one way that someone could be involved in research or clinical research is being part of a study, like a trial, where you might get assigned a medication or some treatment to be on, and then you would come back for follow-up and answer questions, get tests done, maybe get imaging done to see how you responded to that treatment. So that's one way that a lot of people might get involved in research, but that's as a participant in a study. Another way, and I think is the question that you're asking, is how can a patient, a person living with this condition, interact with the researchers to help them do their research. And I am trying to learn more about the avenues, both for patients to get involved, as well as for researchers to reach out to interested patients to involve them in specific studies. So the most direct way that I have had this involvement, and this is how I worked with Rich, although it's not how I met Rich initially. I met Rich in 2018 at a Spartan meeting, actually, but it was through the GRA. So we have a very active patient board, and we have a lot of projects that are driven and led by patients in the GRA. So, for example, we have teams that work on communications, translations, plain language summaries or lay summaries, which are summaries of our research publications that are in language that people can understand without any kind of medical or scientific knowledge. So these were all ways that these patients have been involved in our research projects, and also in our major projects out of the GRA, we've had one or two patients just directly involved from the start in advising on the project. So when you start a clinical research project, you start with a research question or set of questions, and then you start designing your study. You decide who is going to be in the study, what questions are you going to ask. If you're collecting data, collecting information, what do you collect? How do you collect it? What outcomes do you care about? How are you going to measure them? So that's like the first very important part of things before you even really start the study. And then involving patients every step of the way. We get the data, we're looking at the results, we're trying to understand the results, we are discussing the results, and then we're presenting the results maybe in some meeting with other scientists, rheumatologists, and then we're publishing the results in the journal. And then when that is done, we're making that plain language summary so that everyone can read about it. So through that, I learned about all the ways, or not all the ways, but some of the ways that patients can really be involved in clinical research. But again, the GRA was this very unique thing where everything sort of came together. So many people were interested, and like these multiple groups formed, and it was not hard to find an interested patient or group of patients that wanted to be involved in one of the projects.
That's cool. And I'll do a small plug for spondylitis.org here. There is a section on here if you are a listener or a patient who's interested in being part of research. There is a whole section on the website that lists participate in research. But I think that's fantastic. And then one question I think is really interesting that has come up before from patients is, how is general research different? How is medical research different from general medical care?
I was trying to understand that question. So medical care would be if you are going to see a doctor, going to a clinic, going to a hospital, and you're talking to a clinician, and they're giving you recommendations or giving you a treatment or ordering some tests. And that's just a one-on-one basis where it's about your health and just about you specifically. Research is about, it may not be about directly providing care or treatment to a person. It's about trying to understand for a group of people with the same condition, or a group of people with the same condition in the same features. What how can we basically provide them better care? So I guess medical research is about more than just the individual person. It's about a group of people, population of people, and how can we provide them even better care than what they're getting? Or we could be studying with the kind of care they're getting now, what are their outcomes like?
And it's safe to say that if a patient comes in, they would know whether or not they're part of a research study.
Oh yeah, you can't. So you cannot be in a research study without knowing that you're in a research study. That would not be appropriate. You have to provide informed consent. Someone has to explain to you that you're in a research study and explain to you what the research study will require you to do and what are the harms and potential benefits to you. So um, I will say that if your your information are collected as part of a medical record and it's no longer attached to your name, that can become part of a research study, but your name has nothing to do with that information anymore. And when we do those types of studies, we're looking at thousands, tens of thousands of people. So um, the risk of your information getting out there is low, and it's also protected by a lot of um, how should I say this? There are a lot of protections against for that type of research, so that people's actual information remains confidential and never gets out.
It's the power of data again, right?
Yes, so it's data, it's your data, but it no longer is connected to you anymore, and it just becomes one piece of like a giant thing.
Yeah, I love.
But there should be no risk to you to have your data used, like analyzed in that way. And then there are also research studies where you are consenting to actually give your data, like provide blood or provide your time, provide answers to questions, that kind of thing. um, so there's also that kind of study.
Okay, great. Uh, this has been amazing. Anything else you want to talk about highlight wise of what you're working on or what you see as bright for the future?
um, I mean, we could always loop back to the mentorship piece, because I wrote about that in my personal statement for this award. And I mean, I really believe in that. And we were talking about how I met Dr. Gensler and how she's functioned as both a mentor and a sponsor for me. So a mentor is someone who um, has this like close relationship with you, teaches you, guides you, advises you on things, advises you on your research, helps make your research better, but also advises you on your career and maybe like what job you should take next. She actually did help me with that because I was in Seattle before, and then I made the move to Boston. But as a sponsor, as someone who um, has power to give you opportunities that open new doors for you, and she did that as well. So she had me go to these big meetings where I get to network with international experts in spondyloarthritis. She got me on like a paper from the very beginning that really got me started. Just things like that. She knows what um, awards and grants are out there, and got me applying, including to this one. So it's just really important, because when you have the luck to meet someone like that who like um, gets you and like wants to support you, it really helps, because it's a really hard road to do research. You're basically trying to fundraise your own salary much of the time. There's a lot of rejection. Getting a grant, getting the funding to do research and to support your salary. Some of the big grants, it's only a 10% chance of getting it. Can take 6 months to write one. You're trying to do this. You're trying to take care of patients. You're trying to do your research. You don't sleep, so it's a hard road, and it really relies on people who take some extra time out of their schedule that they're not sleeping and helping guide you. So for the next generation, for the people I'm mentoring, I want to be able to be that person for people. And I think part of that is realizing that to do it well, you can't overextend yourself and try to mentor too many people. But you need to be thoughtful in what you do, what you can do for each person. Sometimes I'm mentoring, sometimes I'm sponsoring, so I'm giving opportunities, and I'm becoming that senior person who can help lift other people up, because there aren't that many people doing spondyloarthritis research in the world, and especially not that many in the US. And we need more people, because there are a lot of unanswered questions. There are a lot of ways that spondyloarthritis can be treated better. We can always improve, and for that to really happen is that you need to lift up more people who can take up that charge and keep doing it and try to make things better.
Yeah, and somewhere recently I read a stat that said 63% of women have never been mentored.
Yeah, there's another article I read on Twitter. I'm big on Twitter, by the way. Despite some other issues going on with Twitter, I still think it's worthwhile to use it. But there was another article I was reading about mentoring, and it was talking about how women tend to be also over mentored but under sponsored. So someone who is in a position of power, and given the way things are structurally, it's probably a man who's in that position of power, a man who's a senior person. That man would probably more likely recommend a young or junior man over a woman. But women may have lots of mentors, but never that sponsorship that helps pull them up and gives them a seat at the table. You need someone suggesting you for the big roles, nominating you for awards, things like that. Mentorship can help you navigate through things, difficult decisions, but mentorship is not. Mentorship doesn't do everything.
You're making me ask myself a question: if some of the gaps in opportunity by seniority and opportunity by gender and ethnicity are created out of that sponsorship versus mentorship.
Right. And the people who are senior and like in positions of leadership, if they all look around and they see a room and everyone looks like them, they don't think about who's missing. You have to think about I'm just looking at the message. You have to think about what's missing, so that if you don't ever think about who's missing in the room, you can't improve that. You can't make it better. You can't improve the diversity and inclusivity if you think, oh, we're already good, we're fine, we're as diverse as we possibly can be. We've already asked all the people who have the expertise and the know-how to do this thing, and it's no, you always have to keep looking. And if the people, you don't see them, you need to think, well, where in the pipeline are we losing people?
Yeah.
Where can we mentor people?
So that's going to land me on my final question related to inclusion within research. We had a guest on recently talking about much of the literature out there on spondyloarthritis or ankylosing spondylitis was primarily done on men. How does your research, are you working toward inclusivity and including different genders and ethnicities?
Okay, so I actually left this out and I feel bad. So my work with my colleague Maureen Dubril, who is a 2018 Bruckel winner,
Right.
part of this is about addressing diagnostic delay, but also about racial and ethnic disparities leading to a delayed diagnosis in spondyloarthritis. So the part of the problem is that in medical school we're taught this is a condition that affects young men, so men in their 20s and 30s. So you're always thinking about young men, white men, perhaps, and then that leads to a lot of people not thinking about something like ankylosing spondylitis when they see someone who's a person of color or someone who is not a man in their office, and it's not through some sort of like negligent reason. It's just because when you are taught something and it's like in your brain, it's hard to get out of that sort of thinking. But why are we taught this? And is it because our research in the beginning, this old research from decades ago, was flawed? And I think that might be part of it. For example, the thinking that having ankylosing spondylitis or spondyloarthritis is virtually absent in people with African ancestry. But do we really know this? Are there really good studies, really like quality studies of epidemiology in people of African ancestry that can really answer this question? And we don't have quality studies like that. So if you get your data from poor studies, poorly designed studies, or studies that were designed at a time where like you really couldn't study something that rigorously, and you use that to teach people, generations and generations of doctors, then everyone just thinks that this is the truth, but it may not be what's actually the case. And that's how you miss people and not diagnose them in time until it becomes very, very obvious. And in many cases, that means this person is very severe disease.
Thank you for that. And fighting the fight.
Yeah, and actually, I'm part of a mentorship team for someone who is a trainee at my alma mater in Seattle, the University of Washington. And this is someone who actually has a PhD in sociology, and they have an interest in disparities by race and ethnicity. And their research is actually also in this area. So they are doing some interviews to find out what barriers people have faced in their diagnosis pathway, their pathway to getting diagnosed with spondyloarthritis. It's not my research, so I'm not going to speak at length about it, but it's going to be very impactful work when it's finished, because something like this, you'd think someone would have studied it already, but surprisingly no. But this person is doing some things that hopefully we can get out there, and we can get people to face the biases that they might have implicitly when they're trying to diagnose people.
That's great work. I love that. Okay, so I will make sure this is my final question. Do you have one piece of advice you give to patients above all else?
What is my advice? I mean, I think my advice is let me know if you have questions. If you think of questions or you think of something that you didn't ask me, just let me know as it comes up. Maybe that's not the most pithy of advice, but I think that's something I always say, because having someone feel comfortable speaking up and asking questions is important, because the worst thing is they keep it to themselves and wait 3 months to ask me or don't want to tell me something. I'd rather just know and try to answer the question. And if it's a question I can't answer, I'll try my best to ask someone else who might know. But being able to ask questions and just having this sort of relationship, patient doctor relationship, is important. So it's not really medical advice. It's not like everyone should eat more like vegetables, although I think eating healthier is also something that is a general recommendation that you could give. But I think feel free to ask questions, and then feel free to just let me know if something's working or not working.
Yeah. And this goes back, I'll land on this. It goes back to what seems to be your ethos, which is collaborative care and collaborative advancement of the disease, right? I love that. I like that advice a lot. I don't think enough patients advocate for themselves after they walk out of the room.
I think a lot of people are beginning to, but I think there's disparities there too, because it could be cultural, could be other reasons. And I think the people who are responsible for like the systems of communication need to work on this, because it could be really hard for someone to actually talk to me and tell me that something is not going well with their new medication. If someone is connected to a patient portal and they can just type me a message and I can see it the same day, it'll be easy for that person. But for someone else who may not have computer access or can't speak English well enough to like call and navigate the phone tree, it can be really hard. And it's up to us to figure out how to ask the system to fix itself, to fix the system so that it's more equitable for everyone to like be able to do this. Like I often call people to follow up with them, knowing that they probably would not be able to easily tell me if something was not going right with their medication. But it's very hard to do that for a large number of people. So
Yeah.
While I give that as advice, I also have to recognize that it's easier said than done.
Yeah. All right. Well, that should land it. Thank you so very much. This has been wonderful. I love listening on the research side. And again, thank you for your commitment to the community. It's much
Thanks.
appreciated. SpondyCast was made possible by donations from the Spondylitis Association of America's individual members and our show's corporate sponsor, AbbVie. Since our founding in 1983, the Spondylitis Association of America has been the face, voice, and leading nationwide nonprofit educating, empowering, and advocating for people living with spondyloarthritis. Through our extensive work with patients, the medical community, and partners, we provide information and resources to help people impacted by the disease live better lives and champion research to find a cure.